Welcome friends. Today we will discuss about mitral stenosis. Mitral stenosis is almost always rheumatic in origin. Although in older people it can be caused by heavy calcification of the mitral valve. There is also a rare form of congenital mitral stenosis. Now the pathogenesis. In rheumatic mitral stenosis, the mitral valve orifice is slowly diminished by progressive fibrosis, calcification of the valve leaflets and fusion of the cusps and subvalvular apparatus. The mitral valve orifice is normally about 5 cm square in diastole but can be reduced to less than 1 cm in severe mitral stenosis. The patient is usually asymptomatic until the orifice is less than 2 cm square. As stenosis progresses, left ventricular filling becomes more dependent on left atrial contraction. There is dilatation and hypertrophy of the left atrium, and left atrial pressure rises, leading to pulmonary venous congestion and breathlessness. Any increase in heart rate shortens diastole when the mitral valve is open and produces a further rise in left atrial pressure. Situations that demand an increase in cardiac output, such as pregnancy and exercise, also increases left atrial pressure and are poorly tolerated. Atrial fibrillation is very common due to progressive dilatation of the left atrium. Its onset often precipitates pulmonary edema because the accompanying tachycardia and loss of atrial contraction lead to marked hemodynamic deterioration and a rapid rise in left atrial pressure. In the absence of atrial fibrillation, a more gradual rise in left atrial pressure may occur. In the presence or absence of atrial fibrillation, pulmonary hypertension may occur, which can protect the patient from pulmonary edema. Pulmonary hypertension leads to right ventricular hypertrophy and dilatation, tricuspid regurgitation, and right heart failure. Fewer than 20% of patients remain in sinus rhythm, but many of these have a small fibrotic left atrium and severe pulmonary hypertension. Now the clinical features. Effort-related dyspnea is usually the dominant symptom. Typically, exercise tolerance diminishes very slowly over many years until symptoms eventually occur at rest. Patients frequently do not appreciate the extent of their disability until the diagnosis is made and their valve disease is treated. Acute pulmonary edema or pulmonary hypertension can lead to hemoptysis. Fatigue is a common symptom due to a low cardiac output. Thromboembolism is a common complication, especially in patients with atrial fibrillation. Prior to the advent of anticoagulant therapy, emboli caused 1/4 of all deaths. The physical signs of mitral stenosis are often found before symptoms develop, and their recognition is of particular importance in pregnancy. The forces that open and close the mitral valve increases as left atrial pressure rises. The first heart sound is therefore loud and can be palpable, that is tapping apex beat. An opening snap may be audible and moves closer to the second sound as the stenosis becomes more severe and left atrial pressure rises. However, the first heart sound and opening snap may be inaudible if the valve is heavily calcified. Turbulent flow produces the characteristic low-pitched mid-diastolic murmur and sometimes a thrill. The murmur is accentuated by exercise and during atrial systole, that is pre-systolic accentuation. Early in the disease, a pre-systolic murmur may be the only auscultatory abnormality, but in patients with symptoms, the murmur extends from the opening snap to the first third sound. Coexisting mitral regurgitation causes a pan-systolic murmur that radiates towards the axilla. Pulmonary hypertension may ultimately lead to right ventricular hypertrophy and dilatation with secondary tricuspid regurgitation, which causes a systolic murmur and giant V waves in the venous pulse. Now the clinical features of mitral stenosis. The symptoms are breathlessness due to pulmonary congestion, low cardiac output, fatigue due to low cardiac output, edema, ascites due to right heart failure, palpitation due to atrial fibrillation, hemoptysis due to pulmonary congestion, pulmonary embolism, cough due to pulmonary congestion, chest pain due to pulmonary hypertension, thromboembolism due to atrial stasis and atrial fibrillation. So the symptoms are breathlessness, fatigue, edema, ascites, palpitation, hemoptysis, cough, chest pain, thromboembolism. And the signs: atrial fibrillation due to atrial dilatation, mitral phasis due to low cardiac output. On auscultation, there presence of loud first heart sound, opening snap and mid-diastolic murmur due to pressure gradient across the valve. There is presence of crepitations due to left heart failure, pulmonary edema, pleural effusions, and right ventricular heave, loud P2 due to pulmonary hypertension. The diagram shows there is right ventricular hypertrophy, normal left ventricle, there is presence of stenosed mitral valve, and the left atrium is dilated and increased pulmonary artery pressure. Here the echocardiogram in figure A showing reduced opening of the mitral valve in diastole, and color Doppler showing turbulent flow. The diagram shows the first heart sound is loud and there is an opening snap and mid-diastolic murmur, murmur with presystolic accentuation. Rule patient towards left to hear murmur best with low pitched. Use bell of stethoscope at apex. Now the investigations in mitral stenosis. ECG shows right ventricular hypertrophy, that is tall R waves in V1 to V3 leads, P mitrally or atrial fibrillation. In chest X-ray, enlarged left atrium and appendage, signs of pulmonary venous congestion. In echo, there may be seen thickened immobile cusps, reduced valve area, enlarged left atrium, reduced rate of diastolic filling of left ventricle. On Doppler echo shows pressure gradient across mitral valve, pulmonary artery pressure, left ventricular function. On cardiac catheterization, there may be seen coronary artery disease, pulmonary artery pressure, mitral stenosis, and regurgitation. Now the investigations. Doppler echocardiography is the investigation of choice for evaluation of suspected mitral stenosis. Cardiac catheterization may also be required if surgery or valvuloplasty is being considered to screen for coexisting conditions such as coronary artery disease. ECG may show either AF or bifid P waves, that is P mitrally, associated with left atrial hypertrophy. A typical chest X-ray is shown in figure 16.9. Now management. What is the management? Patients with mild symptoms can be treated medically, but intervention by balloon valvuloplasty, mitral valvotomy, or mitral valve replacement should be considered if the patient remains symptomatic despite medical treatment or if pulmonary hypertension develops. Including the medical management, this consists of anticoagulation to reduce the risk of systemic embolism, ventricular rate control with digoxin, beta blockers or rate limiting calcium antagonists in atrial fibrillation, and diuretic to control pulmonary congestion. Antibiotic prophylaxis against infective endocarditis is no longer routinely recommended. Mitral balloon valvuloplasty and valve replacement. Valvuloplasty is the treatment of choice if specific criteria are fulfilled. Although surgical closed or open mitral valvotomy is an acceptable alternative, patients who have undergone mitral valvuloplasty or valvotomy should be followed up at 1 to 2 yearly intervals because re-stenosis may occur. Clinical symptoms and signs are a guide to the severity of mitral re-stenosis, but Doppler echocardiography provides a more accurate assessment. Valve replacement is indicated if there is substantial mitral reflux or if the valve is rigid and calcified. Now the criteria for mitral valvuloplasty. Significant symptoms. isolated mitral stenosis. No trivial mitral regurgitation. Mobile, non-calcified valve, sub-valve apparatus on echo. Left atrium free of thrombus. This diagram shows mitral valvuloplasty. A guide wire is introduced into the right atrium from a femoral vein and the inferior vena cava. The interatrial septum is punctured, providing access to the left atrium and mitral valve. A balloon catheter is then advanced over the guide wire across the mitral valve and the balloon dilated to stress the valve and reduce the degree of stenosis. Thank you, friends.